All right, good afternoon, everyone, and welcome to the Immune Deficiency Foundation's SCID Compass Lunch and Learn. Today, we are taking a look at the importance of long-term follow-up for SCID. My name is Emma Mertens, and I'm the Program Manager of Community Relations at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this program. We are excited to host this event for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. Today's program is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. Before we get started, I would like to point out a few housekeeping items to keep in mind for today's program. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our panelists and be able to hear myself and our panelists speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions at the end of the presentation. You are welcome to submit any questions you have as you think of them throughout the session. Please type them in the Q&A box in the control panel at the bottom of your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember that information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. Many of you tuning in today are doing so because you are an individual, parent, caregiver, or friend to someone living with severe combined immunodeficiency, or SCID. SCID Compass, an educational program of the Immune Deficiency Foundation, is designed to guide parents of infants diagnosed with SCID, people living with SCID, and the medical community through the journey of learning about this rare and life-threatening medical disorder, and to find support to navigate the many health challenges along the way. SCID Compass is supported by a grant through the Health Resources and Services Administration, or HRSA, which is an agency of the U.S. Department of Health and Human Services. SCID Compass was developed through a partnership between the Immune Deficiency Foundation, RTI International, and the Association of Public Health Laboratories, with support from Expecting Health and the SCID Angels for Life Foundation. To learn about SCID and SCID Compass, please explore our website at www.scidcompass.org. The website offers a robust variety of both online and printable resources for anyone eager to learn more about this condition or share information with others. Topics cover every step in a family's SCID journey, from diagnosis to return home and everything in between. It is also available in Spanish, French, German, Portuguese, and Tagalog by clicking on Select a Language in your upper navigation. SCID Compass also offers monthly and annual programming and events. In addition to our lunch and learns, we support all of the great programming that IDF offers to the PI community. This includes forums twice a month, Ask IDF, Get Connected groups, and more. We are also always thinking of ways to bring the latest in SCID to you, such as the SCID Compass Summit. We are so excited to share that registration just opened up this week, and you can click on the link in the slide or visit www.scidcompass.org/events to register. All right, and now I am so pleased to introduce our presenter for today. Dr. Morna Dorsey is the director of the Pediatric Allergy and Immunology Center at the UCSF Benioff Children's Hospital. She also serves as co-director of UCSF's newborn screening program for SCID and is leading the efforts of the CalSCID long-term follow-up project, a component of which is today's program. Welcome, Dr. Dorsey.
Good morning, everybody. Thank you so much, Emma, for that kind introduction. I'm going to see if we can, let me make sure that we can, you all can see my screen, just a moment. Um, okay, so here we go. Okay. Okay, here we go. Hopefully everybody can see my screen. It's a real pleasure for me to be here with everybody. I'd like to thank the organizers for this opportunity to speak about the importance of long-term follow-up for SCID. In particular, what I'd like to do today is to start off with visiting the SCID journey and to highlight some of the long-term follow-up questions that have been raised and that we hope to answer through the CalSCID program. I'd like to touch on some of the aspects of what we're focusing on as we develop the program. And these are needs assessments, health-specific outcomes, data sharing, and education. As many of you are well aware, the SCID journey is filled with numerous milestones and life events. And the image here is meant to highlight some of those, including the first phone call when families receive very difficult news. It's followed by a whirlwind of emotions and stresses. And then you reach a moment in time where immune reconstitution occurs through transplant or autologous gene-corrected cells. In some situations, enzyme replacement occurs, for instance, with ADA SCID. And then you go home and you enter sort of the new normal. And so there's a general consensus based on our work and the work of others, including IDF, in understanding what happens during the short term. But really little is known about what happens in the long term. That said, there are a couple of definitions of long-term follow-up that I'd like to begin a conversation about. The first is when long-term follow-up begins. The Children's Oncology Group defines long-term follow-up as follow-up 2 years after completion of therapy. And this definition has been unofficially used for SCID patients because it's been traditionally the transplant or hem-onc teams who have typically conducted the definitive therapy. However, this doesn't capture the treatment and also doesn't capture sort of the early experience before treatment, which in some cases can be prolonged for conditions like ADA SCID, where enzyme replacement might be a bridge to the definitive treatment with autologous gene-corrected cells. A second definition comes from the federal agency that makes recommendations about newborn screening conditions in general, and that's the Health Resources and Services Administration. And it is defined as treatment and management following a newborn screening diagnosis. This is, I think, a more favorable definition. However, it is also not entirely appropriate because sometimes the diagnostic journey takes a little bit more time. That aside, there's no consensus on when long-term follow-up ends. And so I would submit that long-term follow-up should continue throughout the lifespan of the individual. And most centers, will have similar protocols for early management, but no SCID-specific consensus pathway has been developed for follow-up beyond the initial definitive or post-definitive treatment. And we can ask ourselves, why is long-term follow-up important? Well, SCID is rare, and we need aggregate data to be able to examine outcomes. SCID is also heterogeneous, even within genotypes, and we can see differences in outcomes depending on presence of infection, donor type of conditioning used, if any. And care is received in diverse settings. And so some centers may use serotherapy, some may not use any conditioning. And so there is an incomplete understanding of how factors such as treatment pathways, type of SCID can impact long-term outcomes. And so it's also important that we get a better understanding of the natural history of SCID to help us address some of the questions that you've already posted. And here we see some of some of the questions that have bubbled up from prior work done by SCID Compass. And these are actual questions that SCID families have posed. Questions like, what are the long-term complications post-treatment versus some of the short-term complications? How can I prepare my family and myself and my child for complications that we might face in the longer term? Well, my child needs special services in school. What's the likelihood that they're going to have developmental delays? How can I prepare for my child entering school? What is the likelihood that a patient will need additional treatment when they're older? We know that there are cases of patients who develop waning immunity years past initial definitive treatment, but we don't have very much data on when that occurs or to what frequency that occurs. Also, questions like, how often should a child check in with their immunologist? Is it yearly? Is it every 6 months? Is it only if things are going wrong? And it's really not clear who should be following patients with SCID. Is it the transplant physicians who did the initial treatment, or is it the immunologists that diagnosed them early on? And then moving on from that, we want to find out information about transition of care. We want to know how patients identify or find knowledgeable physicians to take care of them when they become adults. So your questions have become our research focus for CalSCID. And I've listed some of the sort of general topics that we're going to be looking at through the CalSCID program. So this is by no means complete, but this is sort of a sampling of what we're actually going to be studying. So when we approached this project, we said, what's the best way to develop a long-term follow-up program? And we realized that it needed to be comprehensive, and it needed to be family-centered, and we needed input from all of the stakeholders. So we needed input from patients and families, patient advocates, a family-centered care expert, so that we would make sure we kept our eye on thinking about the family as a whole. Public health experts that would help guide us in terms of what are the important health outcomes that affect public policy. Patient navigators who on a regular basis interact with our SCID patients and really understand what their needs are beyond sort of the medical aspects of their needs. And then, of course, clinicians and investigators. So we are fortunate to have really broad support for this initiative in California. And so we have 6 SCID newborn screen area service referral centers, and we've forged consortium to develop and pilot a SCID long-term follow-up program. And this collaboration is facilitated by the fact that the state screening program in California incorporates confirmatory flow cytometry to enumerate lymphocytes as part of the TREC screening. And because, and I believe we're the only state that does that, and because of this, it's really allowed the whole process of screening and identification to become much more uniform, and has encouraged centers to share best practices. So we, we previously published on a case series. Dave Bookbinder published a case series of more recently, and it drew from a lot of the different cases from these centers. And of course, we have a lot of aggregate data as well, published by Jennifer Puck on the newborn screen experience in California. So we felt that it was a unique setting that would allow us to collaborate, share best practices, and then together develop a long-term follow-up program. So these are the centers, our center, UCLA, UC Davis, UC Irvine, UC San Diego, and Stanford. And then we also, as I mentioned in my prior slide with stakeholders, we have partners through the California Department of Public Health and the Genetic Diseases Screening Program, the Immune Deficiency Foundation, and SCID Compass, the Primary Immune Deficiency Treatment Consortium, SCID Angels for Life, and then our data sharing partner, which is the Newborn Screen Translational Research Network. So this is in essence what these are the members of CalSCID, and this is a HRSA-funded project. So next, I'd like to spend a little bit of time on how we're actually going to go about developing this program. And the project goals are to develop a family-centered approach to long-term follow-up care for SCID. And what we want to do is we want to disseminate our findings to families, researchers, providers, and public health experts so that we can ultimately inform public policy. We also want to make sure that we can establish medical homes for all individuals with SCID so that they can identify and feel comfortable with seeking care in a setting that understands their disease specifically and offers care in a comprehensive way. Now, the input is provided by all of the stakeholders listed here. As I mentioned, the CalSCID centers, which is comprised of the 6 clinical centers in California, public health experts from the Genetic Diseases Screening Program, patients and families with SCID through input from IDF, and also patient advocates like Heather Smith and SCID Angels. We're also going to be working with healthcare providers and getting their input through needs assessment surveys, through CIS and the PIDTC. The steering committee, which is comprised of a patient navigator, a SCID expert, patient advocates, and then the clinical centers. And then we're also going to involve immunology trainees, because I think that's a really important factor in making sure that what we develop perpetuates and continues, and that we train the next generation of immunologists who will be taking care of SCID patients in the long term. Some of the major activities includes needs assessments, piloting the long-term follow-up at centers, and then capturing and sharing the data through REDCap. The output will be a program that generates new knowledge in the areas of long-term outcomes, health-specific needs, neurodevelopment, family well-being, and transition of care. So we felt like those were areas that needed further exploration. And then the overarching deliverable is to provide family-centered long-term care and share data to create, hopefully at some point, a national registry and forge partnerships across public health, academia, and clinical care. So let's take a moment to describe the needs assessment activity. And this is, getting input from patients and families and healthcare providers, and really understanding what the current practices are and what the needs are. So the surveys, so there's, a needs assessment survey for patients and a needs assessment survey for healthcare providers. And these were developed by the SCID investigators with direct input from the public health experts, as well as the steering committee, which, as I mentioned, includes patient advocates. The needs assessment surveys have been beta tested by a handful of SCID patients at our center to ensure that the content is accurate and completion of the survey is feasible. And I believe that this survey is currently being disseminated by SCID Compass for patients. So please complete the survey if you come across it. It will really help inform how we shape this long-term follow-up program. And then the PIDTC and the CIS will get input from clinicians and healthcare providers who transplant SCID patients, diagnose SCID patients, and follow patients in the long term. The protocol will be then refined using the information received from both groups. And then the final protocol will then be implemented at the SCID centers. And this is a 2-year project. So we hope to get data from 2 time points, one sort of baseline, and then at least one 1 year at the 1 year follow-up time point. So the goals are to create, refine, and then implement the long-term follow-up program. The patients and families needs assessment surveys focus on a couple of areas. So we want to get a sense of what the informational, emotional, and financial needs are. And, I think work done through SCID Compass has really painted a better understanding of what the informational needs are, at least in maybe the initial time period when the diagnosis is made. But we're also looking at the informational needs beyond that time period, moving into long-term follow-up. We want to get a sense of, what you're currently using for information, what type of information would be most helpful. And then we really hope to create sort of education material that we can then share with patients and families, and then healthcare providers on the flip side as well, so that they can, when they're talking with their patients, they can say, here, this is year 10, or this is year 5. These are the things that we need to be aware of and that we will be surveilling. And so the survey also contains questions about development and school readiness, the challenges they face there, and also whether they have a medical home. Do they feel as though they have a place where they can get comprehensive care for SCID? And that's a really important part of this sort of HRSA initiative, is to make sure that everybody has a medical home. We also want to know if there are any barriers to access to care. Is it because there aren't any immunologists within, 100-mile radius, or is there are there financial barriers? Is there a cultural language barrier? So some of these barriers are really important to understand so that we can improve them. And then we want to know about transition of care, and if they've gone through that process, how it went, and when it occurred, and how easy it went or how difficult it went. For the healthcare providers side, we're focused on current practices and what each center does for transition of care. Do they implement developmental assessments at certain time points? Is there an assessment of family well-being? And what are their informational needs to be able to better care for their patients? Hopefully, in general, we hope to create educational content, whether that be through webinars or documents that they can share with their families at different time points in follow-up. So next, I'd like to touch on some of the health-specific outcomes that CalSCID will be focusing on. This is part of the overall activity of developing a way to monitor health-specific outcomes, which include immune function, neurodevelopment, family well-being, and transition of care. And so coming out of this will be sort of the new knowledge that we generate from following these previously understudied aspects of long-term care. So in terms of health-specific outcomes and immune function to date, the focus has been on survival and less about outcomes beyond survival. And that's because SCID is considered to be a medical, emergency, and still is, which is why we are, as soon as we see a really low TREC or abnormal lymphocytes, we get on the phone and either have patients come to the hospital to complete the rest of their workup, or if we feel as though the home isolation situation is adequate, we will allow some of that workup to be done outpatient, but it depends on each individual setting. And before the newborn screen era, patients were most often identified due to severe infection, and the focus was on immediate survival. So now, with early identification through newborn screening, transplants are being conducted in a much more controlled setting. Jen Heimel's done some really great work in outlining what, the importance of late effects in a paper that highlighted the need for long-term follow-up to answer the questions of how long does the new immune system last for patients with SCID. Some patients will need a second transplant or a stem cell boost years after transplant. Through efforts of the PIDTC, we've begun to get an understanding of what successful early immune reconstitution looks like. Eli Haddad in 2018 conducted an important study that identified having a CD4 count of greater than 500 at 6 months is associated with improved survival, and having greater than 200 naive CD4 cells associated with improved immune function and survival. So we're getting there. We're getting more information. We're understanding what some of the early benchmarks are for durability of immune reconstitution, but really don't have information beyond typically the first 5 and maybe even 10 years post-transplant. And that's the information that we hope to gather through CalSCID. What happens at year 20, 30, 40, 50, et cetera. So by looking at that, we'll be able to get a sense of what the predictors are of waning immunity in later years. We want to be able to create guidelines for frequency and type of immune evaluation, because that isn't established yet. How often should patients be seen for SCID? Is it every 6 months? Is it every year? Is it every 2 years? I think most of us would say every year is good, but we really don't know what's currently being practiced, and really don't know what's feasible. Do we have enough workforce to be able to see patients, all SCID patients yearly? And who sees them? Is it the adult immunologist? Is it the adult transplant physician? So a lot of big questions there. We also want to know how novel treatments impact immune function. In the newborn screen area, again, there were 2 main reasons for SCID mortality that were identified. One was, CMV infection, and the other is SOS, and that's sinusoidal obstructive syndrome, previously known as VOD. And we know that there's some novel therapeutic clinical trials that are underway looking at lentiviral gene insertion therapy and other therapies, serotherapies like anti-c-Kit antibody is an approach to avoiding some of the toxicity associated with busulfan. And so we need to know what some of these outcomes are, so that we can better understand the impact of these treatments in the long term, and on specifically on immune function. And then, a big question that always comes up is what happens with IgG replacement? How long is it usually needed? When can it be trialed off? And what are each center's approaches to stopping IgG replacement therapy? What are the criteria? So health-specific outcomes beyond immune reconstitution are also really important to capture. And we'll be looking at patients, whether patients are being, diagnosed, when they're being diagnosed, and when they're being followed by subspecialists in these specific categories. So we want to know who's following them in the outpatient and how often they're being followed in the outpatient. And these are this is the comprehensive list of categories of specialties that a patient we felt might seek services. I'll just highlight a few here. We know that, for instance, ADA SCID patients and those with CMV infection have an increased risk of hearing impairment. Endocrinology services are needed more frequently in radiation-sensitive SCID patients due to the conditioning regimen that has an effect on their linear growth. We want to understand when genetics teams are being consulted, and especially if genetics consultation is offered to families early on in the diagnosis. And if it's offered again to patients once those patients become childbearing age, or if they're ready to start their own families, because that's a hugely important topic that I think needs to be addressed at least 2 time points. One, when the initial diagnosis occurs, so that the whole family unit understands what the impact is, and then once they're ready to start their families. We'll look at things like recurrent infections and how often that occurs in patients that are on IgG therapy, and what happens to those conditions once they're off IgG therapy. And so we'll also be looking at nutrition and feeding, because we know that those are important long-term predictors of long-term survival. So this is kind of a comprehensive list, but we want to know what is the medical burden, where are patients going, and look at this at various time points throughout their lifespan. Okay, sorry. I don't know what happened here. Okay. Okay. So we also want to know about neurocognitive development in the long term. And so prior to newborn screening, patients often presented with serious life-threatening infections, as I mentioned, including meningitis. So it's important to really understand what the impact is of newborn screening. And, you know, newborn screening is certainly improved, shortened the timeline between diagnosis and treatment. But we really don't understand, how the sort of early diagnosis and treatment affects neurocognitive and emotional development in childhood. We know that there are, you know, personalized, there are current studies that implement personalization of tissue exposure to busulfan rather than, you know, using milligrams per kilogram dosing of busulfan to minimize the amount of chemotherapy exposure and potentially neurotoxic effects. And so there's really a paucity of literature on outcomes following transplant and the impact of neurocognitive development in different SCID genotypes and different conditioning regimens. And hopefully sort of this personalized tissue exposure to busulfan will demonstrate positive effects on neurocognitive development. We know that neurocognitive outcomes are different depending on type of SCID. You know, we see ADHD more in ADA SCID. And then we also want to know if enzyme replacement therapy versus allogeneic transplant versus gene therapy has different impact on neurodevelopment. That would certainly help guide us in the appropriate care for patients and counseling for each patient. So, and then as part of the long-term follow-up program, we're going to be capturing data using standardized surveys. These will not be formal neurodevelopmental assessments conducted by specialists, you know, which is the focus of the PIDTC study in school-age children. But we will be implementing standardized surveys to assess neurodevelopment and school readiness. And then finally, upon that topic, we want to be able to provide guidance on whether 504 plans or IEP plans are going to be on the horizon for different patients so that we can prepare families for when children are ready for school. So beyond health specific outcomes for the immune system and subspecialty services, we want to know about family well-being because we believe happy families, well-adjusted families mean happy children. We want to understand more about what the stressors are during the SCID journey. I think we have been able to investigate some of those early stressors, but beyond the immediate time period into the new normal, we don't have a good understanding what those stressors are. And so we hope to find ways to lessen the psychological trauma and promote well-being. We also want to examine resilience. Post-traumatic growth is a really important part of the SCID journey, and we want to ensure that we can promote that to improve outcomes for families. And this is just an image of kintsugi pottery where some of the broken pieces have now been reinforced to become stronger, and sort of overall, this object has become more beautiful because of some of the flaws. So to do this, we're going to be conducting surveys to capture information in some of the following domains. So family coping, understanding how the family unit is being impacted, not just the child or the parent or caregiver, but the entire family. There's a lot of work to be done about the impact on donor siblings, how they, whether sort of the stress of being part of that whole experience impacts them in the long term. And that's, I think, really important so that we can support them early on. post-traumatic stress will be assessed. And in earlier studies at our center, we were surprised to find that parents exhibited increasing symptoms of post-traumatic stress after discharge from the hospital following initial definitive treatment. So the story doesn't end when patients go home. In fact, some of these elements appear to persist and maybe even worsen. Both moms and dads can experience postnatal depression, and this is heightened when typical bonding activities like breastfeeding stops because of the concern for CMV. So we want to be able to identify families also who have greater psychosocial vulnerability early on, and we want to be able to support them early on, and that can be conducted through using a baseline psychosocial assessment test. So CalSCID will develop a patient navigator toolkit, and this is going to be deployed at each site's clinical center. And this toolkit will then be administered by the patient navigator or social worker to support families. The toolkit will have a menu of support services, including access to mental health, spiritual support, access to an exercise facility, respite care, all in an effort to promote parent well-being. And we understand that needs are different at different time points. Maybe early on, none of this is needed. You really just want to focus on the baby. But it may be that, month 3, you really need to start exercising to get that sense of well-being. So this is a way of improving the communication between families and caregivers. And so to assess the effectiveness of this, we're going to be employing a patient satisfaction survey to get an understanding of whether these things really are helpful or not. So next I want to talk about kind of a really important topic, and that has been looked at by Heather Smith and the IDF, and they published a really important paper which for the first time describes the discordance that's been reported between family expectations of life after treatment for SCID and the actual day-to-day life that becomes the new normal. And what was interesting is that differences were identified in what families reported and what they remembered hearing versus what the providers believed that they had communicated, even in complex gene therapy trials where extensive discussion and consent forms were reviewed. And the theory is that the malalignment that exists between the providers and the family expectations is due in part because we lack long-term follow-up information to accurately inform patients about what life is going to resemble following definitive treatment. So we need to improve our ability to communicate ideas and expectations. So in addition to getting long-term follow-up data to provide what those, provide information on what those outcomes are going to look like, we need to improve and personalize our communication. And so this is an example of a patient persona that we hope to develop for each new family. And so what we hope to do is sort of create a snapshot of their background, what their goals are, what their habits are, and importantly, what their communication styles are. Whether they prefer to receive auditory, visual, or animation, how best they learn about new information, so that we can then tailor our communication accordingly. And so this is just an example of what that could look like for a new family. And then I'm going to finish up with a couple of other aspects of the CalSCID program, and that is data sharing. And the data sharing aspect of this program is really important, because what we want to do is ultimately get the information that we collect into the hands of the general public, investigators, clinicians, and patients and families. And we want to do that obviously in a non-identified, de-identified manner. And there is a platform through the NBSTRN. And this platform is called the Longitudinal Pediatric Data Resource Platform. And it's a tool that supports newborn screening researchers. So it's really focused on newborn screening. And certainly there's a specific platform devoted to SCID. And so once we collect our aggregate data, we will then share that through this particular platform. And so as we hopefully move from collecting state data, we can then move on to potentially collecting national data if this protocol begins to be implemented at other states. This will then drive research. It'll drive hypothesis-driven research. And then this will then impact public health because we'll see the outcome of the research questions that we posed, and this will change the way we either diagnose or take care of patients with SCID in the long term. And ultimately, what we want to do is improve healthcare quality. So data sharing is an important aspect of this project in general. And finally, I touched upon a little bit the importance of involving the next generation of care providers. So there's a current shortage of knowledgeable providers that can feel comfortable taking care of patients with SCID. As you know, immunologists really train in the field of allergy and immunology, and the field is heavily skewed toward specialists in the field of allergy. But I think the field of immunology certainly is growing, and we need more people to be comfortable with primary immunodeficiency in general. And it's important because these are the individuals who will be following patients in the long term as they become older. And it's also important that we provide enough knowledgeable clinicians so that every individual with SCID will be able to identify a medical home and find a provider that can take comprehensive care of their SCID needs. So the conclusions are that our hope with CalSCID is that we can provide SCID-specific care throughout the lifespan of patients, that we can, through the use of, through the aggregate data and understanding the natural history, we can inform future research, which can then ultimately inform and influence public policy. And fundamentally, of course, we want to take better care of our patients. So this is just an acknowledgement slide. These are all the people that have worked on this project. I want to talk about Linda Frank, who is a family-centered care expert who worked with me in putting together some of the important ideas, along with, of course, Jennifer Puck and Mort Cowan. Xinhua Chen is our patient navigator and is really instrumental in understanding needs of our patients and families. Kathy Nguyen is our research coordinator who has done an amazing job along with Emily Steekel. Kelsey Ige is one of our fellows working on this project currently. And at the different centers, these are all of the site PIs. Manish Butte at UCLA, Victoria Dimitriadis at UC Davis, David Bookbinder at Children's Hospital Orange County or UC Irvine, Kathy Collins at UC San Diego, and Ami Shah at Stanford. And of course, representing patients and families and advocates, including Heather Smith, Amy Brower, and then the IDF team, Alyssa Creamer, Emma Mertens, and then from the Genetic Diseases Screening Program, Stan Scorantino from the California Department of Public Health. And these are all the other institutions that have been working with us on this project. So it's, I know that was a whirlwind, but it was really a pleasure for me to share that with you. And I'm happy to answer any questions.
Wonderful. Well, thank you so much, Dr. Dorsey, for putting together this presentation. It was really neat to get kind of a deep dive at the SCID project, and we're so excited and honored to be a part of it. So thank you. All right, so let's see. Thank you again, Dr. Dorsey. That was wonderful. All right, so now we are going to open it up for some Q&A. So we have a couple questions in the box, but I do want to remind everyone as we're chatting, feel free to pop in any questions you have into that Q&A box. I see someone is raising their hand. We can't allow participants to actually speak or share video on this. So if you have questions, again, please type them in the chat or in the Q&A. All right, first question. All right, Dr. Dorsey, do you ever envision other states adopting a similar program like this one you're building in California?
So our hope is that when we develop this comprehensive program and we pilot it in California, that it could eventually serve as a model for programs to adopt in other states. And so that's our goal. Yeah, I think it'll be important to find out whether or not we're capturing all the information that we need. And I said, California is kind of a unique setting where we have the confirmatory testing associated with the TREC value. So it makes it a little bit easier to provide uniform care. But so that's our hope, is that it becomes a national project.
Wonderful, thank you. All right, next question. If my child was born diagnosed with SCID and still lives in Florida, but we received treatment in California and follow up there yearly, would we be a part of this project?
Yes, so what we're looking at is for any patient who is currently receiving their SCID care at one of our centers in California, they would be eligible to enroll in this particular program. And then in terms of frequency of follow-up, I think beyond the first 2 years, at a minimum, a yearly follow-up is important.
Perfect, thank you. It looks like that's all the questions we have in the box for now. We just want to thank you again, Dr. Dorsey, for putting together this awesome presentation. We are so excited. This will be our first of 3 collaborative lunch and learns with the SCID project, so more to come soon.
Thank you so much for this opportunity. Have a great rest of the day.
Thank you. All right, so we just want to remind our audience, we have a couple more things to run through before we close it out, that if you have more questions or questions beyond today's topic, that you can ask IDF, go online and submit your questions to www.primaryimmune.org/ask-IDF, or give us a call at the number on your screen and we will answer whatever questions you have. We hope you'll remember to take advantage of all of the resources that SCID Compass has to offer, including our family planning guide and SCID fact sheet, which we offer in 2 versions, one for parents and one for providers. And we also want to highlight our SCID Compass toolkit for parents, which encompasses all of the resources and info found on our website in a printable, easy to read guidebook that is now available in over 11 languages. Finally, I do want to encourage anyone who's tuning in today who is a SCID patient or a parent or a caregiver to someone living with SCID to participate in the CalSCID Needs Assessment Survey that Morna talked about today. Please scan the code on screen. This QR code will take you directly to the survey link. And I also added in the chat a link to IDF's blog that just came out that also links directly to the survey. So this also has been emailed out to anyone on our IDF listserv who has indicated some sort of connection to SCID. And if you haven't received it, send an email to SCID Compass at Primary Immune and we can send you the link directly. Finally, sorry, another survey. We want to close by saying that SCID Compass and IDF programming is really guided by the individuals and families we serve. So we hope you'll take a brief moment to scan this code and take our program evaluation survey. It takes all of 30 seconds, and this will also be emailed out to everyone after the webinar. And finally, I want to just let everyone know that we will be going on a summer break from our monthly SCID Compass Lunch and Learns as we gear up for the summit in June, but we hope you will join us for the next SCID Compass program in August on B-cell reconstitution and IgG infusion for SCID. And that will be the second program in our CalSCID SCID Compass Lunch and Learn series. So thank you so much again, Dr. Dorsey, for your time today. Thank you everyone who joined for taking the time to be a part of today's program. We really appreciate you and hope you have a wonderful rest of your day. Thank you.